We have 4 lung volumes, we have 4 lung capacities. So lung volumes, what are lung volumes? Lung volumes are nothing but the volumes of air breathed by an individual. So we have 4 type lung volumes. One is tidal volume, one is inspiratory reserve volume, one is expiratory reserve volume, one is residual volume. In this diagram, you have everything covered, 4 lung volumes as well as 4 lung capacities. So actually the total lung capacity is 6 liters. You can see this axis, volume of air in the lungs in ml. It is written as ml. 6000 ml means 6 liters. So this is a total lung capacity. This all together is a total lung capacity completely. So we have totally 6 liters. That is our normal value. 6 liters we have. We have certain levels known as maximal inspiratory level, resting inspiratory level, resting expiratory level, maximum expiratory level. So the one which I am pointing now, the topmost is the maximal inspiratory level. Like when you inspire maximum, when you take a deep inspiration, this is the maximum level you can inspire. The first part, the top line, this line, the first line what you see is the maximal inspiratory level, the maximum to which you can take an inspiration. So that will be maximum to 6 liters it will go. Okay. So in between you can see the second line. The second line, this is the resting inspiratory level. Resting inspiratory level. This is the maximum inspiratory level. This is the resting inspiratory level. This is the resting expiratory level. And this is the maximum expiratory level. So we have mainly 4 lines you have to see. Maximum inspiratory level, resting inspiratory level, resting expiratory level, and the maximum expiratory level. This is the maximum expiration. So beyond this you can see some empty space there. Like even after your expiration, deep expiration you have some amount of air remaining in the lungs. That is known as residual volume. That is the volume of air that remains in the lungs even after the deep expiration. Even after full expiration, the amount of air that remains in the lungs, that volume is known as residual volume. That's what the last space, you can see a space there. There is no graph there. So we have 4 lines mainly. Maximum inspiratory level, that is the maximum area a person can inspire. The second one is resting inspiratory level, means resting inspiratory and resting expiratory means based on the tidal volume. A person normally breathes a particular amount of air, that is around 500 ml. It can be 400 ml, 500 ml. You can see this is the tidal volume, this area, resting inspiratory level and resting expiratory. This is normal breathing. This is what a normal breathing. You can see the normal breathing, see the graph here. This is the normal breathing without doing anything. When you take a deep inspiration, what happens? See this. When you take a deep inspiration, that is something known as the inspiratory reserve volume. See this. From the resting inspiratory level to the maximum inspiratory level is the inspiratory reserve volume. You are taking an extra effort, like other than the normal inspiration. Again, when you come back, take a normal respiration, then you take a deep expiration, then you fully expire out, you can see a graph going down, that is the expiratory reserve volume. See this is the expiratory reserve volume. So from the the resting expiratory level to the maximum expiratory level is the expiratory reserve volume. Again it will keep on going. So this is a normal graph, you can see a normal graph here. This is a tidal volume, a normal amount of air breathed in and out of the lungs is the tidal volume. See this 2500 to 3000, the total amount is 500 ml. So that is a normal tidal volume. And 1200 is the residual volume. So from 1200 you have to go up till 6000. This all together is known as the vital capacity. From the maximum inspiratory level to the maximum expiratory level. Like you take a deep inspiration and you forcefully expire out, the complete thing is known as vital capacity. That is around 4.8 liters, means 4800 ml. Capacity means either addition of 2 volumes or 3 volumes. For example, you can see the total lung capacity means it adds all the 4 volumes to get a total lung capacity. If 6000 ml is the total lung capacity, it is the addition of inspiratory reserve volume, tidal volume, expiratory reserve volume, residual volume. All together is added and it constitutes about 6000 ml or 6 liters. Whereas inspiratory capacity is the addition of tidal volume and the inspiratory reserve volume. So if you see from 2500 to 6000, it's coming around 3500. It's a rough estimation. Okay, it's like coming 3300, 3100. It comes here and there. So approximately from 2500 to 6000 is the inspiratory capacity. Inspiratory capacity is nothing but the addition of the tidal volume and the inspiratory reserve volume. See the functional residual capacity. It is the addition of expiratory reserve volume and the residual volume. And there is no expiratory capacity here. We have inspiratory capacity, we don't have expiratory capacity. We have something known as functional residual capacity. Okay, don't think expiratory capacity is there. That's a frequent mistake what everyone writes in the exam. You think that inspiratory volume is there, expiratory reserve volume is there. Similarly, you write inspiratory capacity and expiratory capacity. There is no expiratory capacity. We have inspiratory capacity and functional residual capacity. So see the vital capacity. Vital capacity is nothing but the addition of inspiratory reserve volume, tidal volume, and expiratory reserve volume. So you can see the normal graph, tidal volume around 500 ml. Inspiratory reserve volume is the resting inspiratory level to the maximum inspiratory level. Expiratory reserve volume is from the resting expiratory level to the maximum expiratory level. The amount of air remains in the lungs even after the full expiration is the residual volume. So when you do a spirometry, you can't assess the residual volume. So without getting residual volume, you can't assess the functional residual capacity. You can't assess the total lung capacity. So the limitation of spirometry, when you do a spirometry, you can't assess a residual volume. So I'll come one by one. What is tidal volume? Tidal volume is the volume of air breathed in and out of the lungs in a single normal quiet respiration. Like when you talk normally, when you do a thing normally, you're not bothered about that. So normal air, what is breathed in and out is the tidal volume, and it is not 500 ml fixed for everyone. We normally tell it as 500 ml. It can be 400 ml also. It can be 350 ml. Actually, the normal value is based on the kilogram of a person. 6 to 8 ml per kilogram is the tidal volume. 6 to ml per kilogram. Like suppose 40 kg, a person is 40 kg. 40 into 6. That is the way you see. So normal value is based on 6 to 8 ml per kg. Tidal volume falls with decrease in compliance, decreased respiratory muscle strength, etc. So tidal volume is nothing but the volume of air breathed in and out of the lungs in a single normal quiet respiration. It's a normal breathing, you say, in a simple word. Inspiratory reserve volume. Inspiratory reserve volume is the additional volume of air that can be inspired forcefully after the end of normal inspiration. I have shown the diagram. After the normal inspiration, what is the additional amount of air inspired here? That is the inspiratory reserve volume. Whatever additional amount of air you inspire, that is known as the inspiratory reserve volume. So see the graph here. You can see the inspiratory reserve volume, the blue colored. So additional amount of air after this resting inspiratory level is known as the inspiratory reserve volume. So it comes around 3300 ml. After that resting expiratory level, the amount of air expired is known as the expiratory reserve volume. So you can see the graph here. After the tidal volume, in the sense, after that normal, the resting expiratory level, what comes down extra expired amount of air is expired, that is known as the expiratory reserve volume. The additional volume of air that can be expired out forcefully after a normal expiration is known as the expiratory reserve volume. It comes around 1000 ml.
What is residual volume? The volume of air remaining in the lungs even after forced expiration is known as residual volume. The normal value of residual volume is 1.2 liters. Residual volume is indirectly measured, can be measured by FRC minus ERV, that is functional residual capacity minus expiratory reserve volume. It cannot be measured by spirometry. So residual volume cannot be measured by spirometry. That is one of the limitations of spirometry. So significance of residual volume. Residual volume helps in exchange of gases between breathing and during expiration. And residual volume maintains the shape of the lungs.
So from here we have 4 capacities. First one is the vital capacity. You can see the vital capacity. It is the addition of what? Inspiratory reserve volume, tidal volume, and the expiratory reserve volume. So inspiratory reserve volume, tidal volume, and the expiratory reserve volume. All these 3 together is added and it comes to vital capacity. Next comes the total lung capacity. It is the addition of inspiratory reserve volume, tidal volume, expiratory reserve volume, and the residual volume. All these 4 adds to form the total lung capacity. See the functional residual capacity. It is the addition of the expiratory reserve volume and the residual volume. Then comes the inspiratory capacity. Inspiratory capacity is the addition of the inspiratory reserve volume and the tidal volume. So these are the 4 capacities. So if you know the volumes and the different levels, you can just assess the capacity also. And capacities are a combination of 2 or more lung volumes. There are 4 capacities: inspiratory capacity, vital capacity, functional residual capacity, and total lung capacity. So one by one, inspiratory capacity, it is nothing but the addition of tidal volume and the inspiratory reserve volume. Okay. If you try to mug up here directly, what happens? You get confused. So better you study with the graph, then you write by your own. So if you know the value, you can draw there correctly. If you get the volumes correctly, you can get the capacity. Directly, if you go to the capacity and then you study the volume, everything is ulta pulta. So first you study the different lung volumes, the normal value, then you add together and write here. So inspirator capacity is the combination of tidal volume and the inspirator reserve volume. It comes around 500 plus 3300. So it is 3800 ml. Again, it is a value based on the previous this thing. Normal range is a big range. Vital capacity is nothing but the maximum volume of air that can be expelled out forcefully after a deep inspiration. You take a maximum deep inspiration and then you forcefully expire completely out. That is the vital capacity. That means it includes inspirator reserve volume, it includes tidal volume, it includes expirator reserve volume. So 3300 plus 500 plus 1000, 4800. One more capacity we have is total lung capacity. There no confusion is there. Every volumes you add. The volume of air present in the lungs after a deep inspiration. Everything you add. IRV plus TV plus ERV plus R. All the four volumes you add. You will get 6000 ml or 6 liters. So functional residual capacity is nothing but the volume of air remaining in the lungs after normal expiration. It includes ERV and RV. It is around 2200 ml. It cannot be measured by spirometry. There are certain methods we can measure by the FRC is the helium dilution method, nitrogen washout method, the body plethysmography method, etc. So this many significance are there. Reduces the work of breathing. It helps us access an oxygen store for the lungs. It acts as a buffer for maintaining a steady partial pressure of oxygen. It maintains a residual volume constant in a constant way, like 1200 ml means in that range only it maintains. It keeps the airway resistance low. What are the factors affecting FRC? There are certain factors which can increase the FRC in conditions such as emphysema, bronchial asthma, in old age because due to the elasticity is lost in old age, atelectasis, also known as collapsed lung. These are the factors affecting FRC. What are the measurement of how do you measure FRC? Like you can't measure with a spirometer. So you have a different methods known as open circuit method, closed circuit method, and a body plethysmograph method. So I'll just tell you about two methods. First, open circuit method, you have a nitrogen washout method. In nitrogen washout method, the subject is asked to breathe normally, and what happens after a normal end of normal expiration. When you take inspiration, you take expiration. At the end of normal expiration, that subject inspires a pure oxygen through a valve and expires into a Douglas bag. We have a Douglas bag required for doing a nitrogen washout method. I don't have a picture, so sorry to show that I didn't get a picture of this. So I'll just tell the method. The subject is asked to breathe normally. After the end of normal expiration, the subject inspires pure oxygen through a valve and expires into a bag known as Douglas bag, which is done repeatedly for 6 to 7 minutes. 6 to 7 minutes he'll be doing the same procedure. He'll be breathing. He'll take a normal respiration. At the end of normal expiration, the subject inspires a pure oxygen and he'll be expiring into a Douglas bag, and this procedure we do it repeatedly for 6 to 7 minutes until the nitrogen in the lung is displaced by oxygen. So until this method is done, until the nitrogen is in the lung is displaced by oxygen. So there's a calculation based on this. When the volume of air collected in the Douglas bag at the end of experiment is taken, the concentration of nitrogen in the collector is taken. So we have a rough calculation, the equation C1 into V by C2. C1 is nothing but the concentration of the nitrogen in the collected air. C2 is the normal concentration of nitrogen in the air, and V is the volume of air collected. So this is about nitrogen washout method. The next method is the main commonly used method in FRC, known as helium dilution method. So helium dilution method, you can see a diagram here. What is A and B? Actually, the technique is used. We need a spirometer here. Okay, the spirometer is filled with air containing a gas known as helium. The name of the technique is helium dilution method. So we have a spirometer. Spirometer is filled with air containing a quantity. You can see a spirometer. See the A diagram. See this. What is this? This is a spirometer. It contains helium. Okay. Picture A and picture B. You focus on picture A. You have a spirometer which is filled with a known quantity of helium. The subject first takes a normal inspiration, then he takes a normal expiration. So after the normal expiration, like our nitrogen washout method, at the end of normal expiration, what happens? A subject breathes from this spirometer. So after a normal expiration, at the end of normal expiration, instead of Douglas bag, what we have in nitrogen washout method, we use a spirometer which contains a known quantity of helium. And this person, what happens? He just inspires that spirometer, whatever is there in the helium is there in the spirometer, he inspires that. So the helium gets diluted with the FRC of the lungs, and it attains a uniform concentration in the spirometer. See the second diagram. First diagram is showing the spirometer with a known quantity of helium. The patient is inhaling that. So the second picture you see, it is a uniformly, it is the helium gets diluted to the FRC of the lung. See, it reaches to the lung here. This is the FRC of the lung. Okay. Suppose this diagram is showing the FRC of the lung. It is uniformly, the concentration is attained in the spirometer as well as the lungs. That's the second picture. First picture was a spirometer containing quantity of a helium. The person inspires that, inhales that, so that it forms a uniformity between the FRC of the lungs and the spirometer. So this, to determine the residual volume, the subject starts breathing pure oxygen after. So after this, what happens? To determine the residual volume after FRC, the patient is asked to inhale a pure oxygen after taking a forceful expiration. This is how you do a helium dilution method. First, a picture shows the spirometer filled with quantity of helium. The second picture shows a uniformity attained between the spirometer and the FRC of the lung. Okay. So this is a helium dilution method. So you get a value here, C1, C2, V1, V2, etc. So I'll just show the calculation. We have two volumes and two concentrations here, not like our first method. So here we have a value around, because we have an FRC, we have to calculate from this value. For example, V1 is initial volume of air in spirometer is 5 liters. Example, 5000 ml is the V1. C1 is 15%. Initial concentration of helium in the spirometer. C2 is final concentration of helium in 10%. This is the approximate value. Okay, just not, we don't get anything in this diagram. This is a diagram showing the procedure. So certain values are assuming if the value of V1 is 5000 ml. If C1 is 15%. The second one, the final concentration of helium is less, because see the concentration here, it was more, 15%. Suppose this is 15%. This is only 10%. That is C2. V1 we have around 5000 ml in this. So we have to calculate the V2. Means we have a formula known as C1 into V1 is equal to C2 into V1 plus V2. That is a conservation of mass principle applying for the FRC helium dilution method. So we had to calculate V2, which is known as our FRC. To get the FRC, we will be measuring the, based on the above values, we will get a value of 5000 into, that is V1 into C1 minus C2, that is 15 by 100 minus 10 by 100. Divided by 10 by 100 is equal to, you will get a value of 2500 ml based on this values in this particular experiment. This is an assumption. Okay, this is like a rough. We have 15% here, we have a 10% here, we have a volume of 5000 ml here. We have to calculate the volume of the second, the V2, that is FRC. Okay, we told that it is equally attained in the, everything is equally attained. So what is this volume? This volume we are calculating based on the other thing. So this V2 FRC we are calculating based on the values we are getting from the V1, C1 and the C2. So that's a rough calculation based on the certain values. If the values are changed, again the calculation changes. So what is vital capacity? Vital capacity is the maximum volume of air that can be expired out forcefully after a deep inspiration. It contains tidal volume, inspiratory reserve volume and expiratory reserve volume. This is already told to you. What are the factors affecting vital capacity or variations that affecting the vital capacity? Physiologically, gender can be affected. Like males will be having more vital capacity. Even body build, VC or VC means vital capacity. Okay, don't think in other way. Now I'll tell VC. VC means vital capacity, not the vice chancellor. So here we see vital capacity is slightly more in heavily built persons. VC is directly proportional to the height of a person. VC decreases with increasing age. VC is more in standing position than in the lying and sitting position. VC is more in athletics. VC is more in swimmers. VC is less in pregnancy. So these are the physiological variations you should know about the vital capacity. This is more in males compared to females. It is inversely proportional to the height. It is slightly more in heavily built persons. It is decreasing with increasing age. It decreases in pregnancy. It increases in athletics. It is increased in swimmers. It is more in standing position than in the sitting and the lying position. It is more in swimmers as well as who do a daily exercise also. Daily exercise like footballers, like they have more vital capacity. Basketball players, daily who's playing, they also have a more vital capacity. So pathological variations, when you have a pulmonary diseases like pneumonia, you have chronic bronchitis, emphysema, COPD, bronchial asthma, anything, any lung diseases, anything affecting the lungs, it can decrease the vital capacity. Also, one more thing you can tell which can increase physiologically is that if you daily you do a, like example, if you're doing a spirometry here, if you're daily doing practicing spirometry, you can increase the vital capacity. Experience also comes in increasing the vital capacity. If you do a particular thing to improve the lung function test, you do it daily, you can, through the experience also, you can, it will increase gradually. Sometimes first day if you do, you have only 3 liters, second day you get 3.1. Gradually you can increase accordingly based on the experience and the exercise you do daily. That's also variation. So pathological variation, anything that affect the lungs, any diseases, or it can due to an ascites in the or abdominal tumors, it can be due to the pericardial effusion, any abnormalities in the spinal abnormalities like kyphoscoliosis, kyphosis, etc. Any related to the drugs, depression of respiration due to intake of opioids. So any weakness of the respiratory muscles, all these can contribute to the pathological variation of vital capacity. So that's about vital capacity. So vital capacity can be at what is vital capacity, give the normal value of vital capacity and explain the factors affecting it. Factors means these variations you have to explain. Physiological and pathological, you have to mention it out. What is the limitation of spirometry? As I told you, limitation of spirometry is that you can't record residual volume because it cannot be expired out. If you don't get residual volume, you don't get functional residual capacity, you don't get total lung capacity. So these three things you can't determine with the help of a spirometry.